Just
Yes.
making sure. So it's a great pleasure to have an opportunity to share with all of you some insights over how high frequency ventilation has evolved over many years. I was fortunate enough to be there, not quite this far in 1915, but at the beginning of clinical application. The whole concepts did start with a gentleman who noticed that his dog was panting very shallowly and yet did not appear to have any problem exchanging air. And he demonstrated that with rapid blowing down a tube, you can have a spike of gas penetrating through the resident gas. And that was sort of the earliest concept that taught us that you can ventilate at tidal volumes that are near or perhaps even below anatomical dead space. And so the basic concept of high frequency oscillatory ventilation is that unlike conventional ventilation, where when we apply pressure at the airway opening, that pressure results in flow down the tracheobronchial tree, and pressure eventually equilibrates all the way down to the periphery, and then exhalation can occur. With high frequency ventilation, these swings in pressure occur very rapidly, and there's no time for pressure to equilibrate. And therefore, there is really more of a mixing of gas and complex mechanisms of gas exchange. But the key concept is that as we move peripherally down the tracheobronchial tree, there is progressive attenuation of the pressure and volume swings. And that is one of the two key aspects of lung protective nature of high frequency ventilation. The other, I will tell you as a spoiler to Dr. Van Kamp's presentation, is of course optimal lung volume recruitment. So my task was to briefly discuss classification of high frequency devices. And so I will tell you that there are basically three modalities. Not all of them are widely available everywhere. HFOV is the one most widely available throughout the world. And of course, that generates a symmetrical waveform at a 1-to-1 ratio, or somewhat asymmetric if you choose different ratios. The waveforms are generated by a variety of mechanisms. The operating frequencies range from 5 to up to as high as 20 hertz. Some of the older devices don't have the ability to superimpose recruiting psi, others do. Jet ventilation is primarily available in the US and Canada. There are a few devices in Europe and Australia. This is an exciting and novel way of ventilating. I will spend just a handful of slides to describe it in more detail. It has a lower optimal operating frequency because it depends on passive exhalation. Essentially gas shoots down the airway and returns passively. And then there is something called high frequency flow interruption or percussive ventilation that again generated by a variety of mechanisms. The difference between flow interruption and jet ventilation is that with flow interruption, there is the gas enters the airway without going through that jet nozzle. Some of the flow interrupters do have a negative inflection, somewhat of an active exhalation, but not nearly the same magnitude as the inspiratory flow. So there's been much discussion over the years about what constitutes a true oscillator, and there's been some misinformation and misconceptions out there because the baby does not care how the waveform is generated. The baby's lungs care about what is the waveform, what does the waveform look like? And so what makes a true oscillator is a device that can generate a true sinusoidal waveform with equal positive and negative pressure deflections. And it doesn't matter how that is generated. So at 1-to-1 ratio, it's both positive and negative are of equal magnitude. If you use a 1-to-2 RE ratio, the pressure deflection will be less, but the volume deflection is equal. So equal volume of gas, equal flow goes in and out, and that makes a true oscillator. Some of the older devices clearly were not quite up to that. So How are the oscillations generated actually is quite variable, and some companies kind of try to keep it a secret. Some they are mechanical piston oscillators. The Hummingbird was the prototype of that, and they still use a mechanical piston, which pretty much limits them to a 1-to-1 inspiratory-expiratory ratio, and that turns out may not be optimal. Then, of course, there is the loudspeaker, so-called piston oscillator, and that's the prototypical oscillator, the Sensormedics 3100, and also I believe the Dragonfly uses the same mechanism, although that was hard to find. There are other oscillators, other devices that no one argues are not oscillators that generate the deflections by a reverse jet mechanism, the SLE, for example. The Stefan device uses sliding valve system that directs gas flow to or away from the patient. And then there are several devices that use a powerful venturi or membrane to generate the negative deflection. Again, what matters is it a symmetrical waveform of equal magnitude going in and out? So there are lots of different devices out there. And it's important that we understand the device that we're using so that we know its limitations and we know its strength and we know how to optimally deploy it. There are some devices historically that were out there that were true flow interrupters. The Infant Star was one of them, and several fairly large studies were done using the device, and they did not have very good results for reasons we'll discuss in a moment. The Bronchotron is a US device and is not available elsewhere. The old Babylog was somewhat of a hybrid between an interrupter and an oscillator. It did generate mostly adequate expiratory deflection, but it was not a powerful enough oscillator. In some circumstances, it had limitations. The new Draeger is a much more powerful device. So there's been a lot of studies that suggest that the not quote unquote not true oscillators are not equally powerful. It's true that, for example, the Draeger VN500 does not quite have the same horsepower as the Sensormedics. But I will tell you that few of us use high-frequency ventilation needing a tidal volume of 15 mL. In fact, of course, typically we are going to use high frequency at high frequencies. Whoops. And for my purposes, tidal volume of 5 mL is your biggest baby you're typically going to ventilate, right? 5 mL per kilo. No. You typically use 1.5 to 2 mLs per kilo, so up to 2 kilo, you do fine. And if you use a slightly lower frequency, you can generate what you need. There is this well-known relationship between tidal volume and frequency that is reflected here. So we had spent a lot of time over the years arguing about which ventilator is better. But we, I think, can finally overcome that, and we can look back at a wise person who wrote an editorial in 1965 that points out what we have all come to learn over the years, which is that arguing about virtues of respirators not invented over those readily available can be ended now that it is abundantly clear that the success of such apparatus depends on the skills with which it is used. In other words, it's not the hammer, it's the carpenter. It's how well we are using the device at our disposal, because not everyone has access to the best devices. And yes, some devices are better than others. But if you know what you are doing, you can do well even with not the greatest machine. It's what you have. You have to use it carefully, use it well. All right, so the other task was to kind of take us through the history of high-frequency ventilation. And Dr. Rajiv gives me far too much credit, but it started really clinically in Scandinavia. Dr. Sjöstrand in 1960, something called high-frequency positive pressure ventilation. This was employed in adult patients. it worked, it had benefits. Then people moved on to oscillatory ventilation with some bench experiments. Dr. Lunkenheimer in 1970s, using a piston oscillator, demonstrated in principle you can very effectively ventilate. And then the, jet ventilation began to be used in adult patients. Dr. Sanders started using it during airway manipulation. And two Czech doctors, Mira Klein and my dad, Hugo Keszler, worked in Pittsburgh on some clinical applications of high-frequency jet ventilation. So I came into this with some pedigree, I should point out. Then there were folks in Toronto, in Canada, who developed clinically some application of oscillatory ventilation in the 1980s. Bob DeLemos down in the US was instrumental, and there were many others that followed. So really clinical application of jet and oscillatory ventilation began in the late 1970s, early 1980s, with jet ventilation being perhaps slightly ahead in terms of clinical application. Tom Harris, Steve Burrows, and I was probably the second or third person to put a baby on a jet ventilator. We did not publish our work immediately, though. And Wally Carlo, Alan Spitzer were also very active in the use of high-frequency jet ventilation. And as I said, we spent a lot of time arguing about whether oscillators or jets are better. Turns out it doesn't matter which you use if you know how to use it well. So back in the early 1980s, this was a jet ventilator that I used. It was a fluidic device. It was quite interesting. We applied the jet through a homemade jet injector. Could not do that today, should not do that today, but that's how we all began a very long time ago. So my early career in high-frequency ventilation involved the jet ventilator. The Bonnell jet came into being in the mid-1980s after I finished my fellowship. And it was an interesting device, microprocessor control, the first neonatal microprocessor control device that has this pinch valve close to the patient and shoots little bursts of gas down the center of the airway, monitors the pressure distally, and adjusts the amount of gas that's being injected to maintain a stable pressure that the clinician chooses. It's a newer device, but it's functionally much the same. This is essentially how it works. So the gas exchange mechanism is somewhat different from oscillatory ventilation. It shoots bullets of gas down the center of the airway, displacing gas that's resident there. There's some simultaneous exhalation that occurs. It can bring up secretions. If you start jet ventilation on a baby with meconium aspiration, you sometimes flood it with meconium. But what's important with the jet ventilator and what's make it a little bit tricky to use is that this jet stream needs to be carefully aimed down the center of the airway. Should not be too close to the carina. You don't want a head turned to the side because the endotracheal tube comes in at an angle and this jet whole thing is broken up. On the other hand, you can take advantage of this jet streaming by what I call a virtual right mainstem bronchus intubation. And if you have unilateral interstitial pulmonary emphysema, as you have in this patient with tremendous overexpansion and tension, you can virtually, and in smaller babies, even a 2 millimeter endotracheal tube may be too small to actually intubate at mainstem bronchus, but you can virtually intubate by aiming that jet stream. And within 12 hours, there's not complete resolution, but the tension has gone away and there's considerable improvement, and this baby continued to improve. So jet ventilators have some unique characteristics that make them particularly useful in air leak, but they're not available everywhere. So then in the mid-1980s, we all started using high-frequency ventilation, but there were really no good clinical trials. So a group of investigators got together and organized this HiFi study group. I was invited, but chose not to participate because they chose to use a ventilator, a hummingbird ventilator, which I did not think was actually the best way to go. We were therefore not involved in that study, and unfortunately that study proved to be quite disappointing. As you can see, many of the outcomes were quite poor, with actually increased air leak, increased need for pressors, increased intracranial hemorrhage, periventricular leukomalacia, and failure of assigned therapy and crossover. It was a very disappointing study. There was a lot of speculation what went wrong. Big part of the problem was that we did not really fully understand how to use high-frequency ventilation. There were many investigators that actually didn't have any experience with this device. Clearly, they did not target the open lung strategy. But perhaps the problem also was the use of the hummingbird piston oscillator with a 1-to-1 IE ratio and without lung volume recruitment, because that can cause air trapping. All the adverse consequences that you see here could in fact be explained on the basis of air trapping. They did not publish any radiographic data. Most of these could also be explained on the basis of inadvertent hyperventilation, certainly the PVL and IVH. And so we really don't know exactly why this trial was so disappointing, but it set the field back many years. In the meantime, though, people persevered, knowing that in their hands, those were not the results that they saw. And perhaps it was because the Sensormedics oscillator that also came on the market in the mid-1980s and has not appreciably changed since, has come into use, typically being used with a 1-to-2 IE ratio, but it has some limitations. It is a dumb ventilator. It doesn't know if you have a thumb over here, a cork at the end of the circuit, or a patient. So we have better devices now, but it is still the most powerful device. And of course, the way oscillators work is there's an electromagnetic piston that moves back and forth, generating these oscillations. The power applied to the magnet determines the amplitude and therefore CO2 elimination. And there's bias flow of fresh gas, and the balance between inflow and downstream resistance sets your mean airway pressure. And it's therefore quite a simple device. You have an oxygenation knob and a ventilation knob, but there is an interaction between the amplitude and mean airway pressure that affect both oscillation and ventilation. It's not quite as separate as people make it sound. So we have very good data over many years of preclinical work that taught us how to use oscillatory ventilation. There was a very nice study published in the year 2000 by Brad Yoder that demonstrated long-term ventilation, this oscillatory ventilation was much more benign in terms of causing lung injury than conventional ventilation. You can see a well-preserved lacy pattern of alveolar formation in these baboons that were biopsied at 7 months of age after they were recovered following a long period of ventilation, whereas the conventionally ventilated animals had the typical new BPD pattern that we see today now in neonates. So there was a fair amount of activity as over the next 20 years or so. This is the HI-FI trial that was quite disappointing. The mean birth weight was 1,100 grams, so bigger babies than we worry about today. It was a large trial, but very disappointing. Wally Carlo published a small study using a jet ventilator with no immediate benefit, but it was a small study. Gratifyingly, there was no increase in intraventricular hemorrhage. I published a trial in 1991 using the jet ventilator. It was a modest-sized trial aiming specifically babies with severe PIE. Important to point out that this is the pre-surfactant era, and a time where conventional ventilation was quite quite brutal, quite poorly done. We did not have synchronization, and we did not understand the concept of volutrauma. So it was relatively easy, perhaps, to demonstrate benefit. So this clearly improved survival and did not have adverse consequences in terms of brain injury. Rees-Clark published a modest-sized trial in babies of similar size as the HFOV trial and demonstrated that actually you can use oscillatory ventilation effectively and safely, no increase in intraventricular hemorrhage. Then there was another trial using the sensomatics in a rescue mode, babies with severe RDS, some with air leak, and mean birth weight was about 1,700 grams. There was a slightly higher incidence of IVH, and the PCO2 was significantly lower. So this is a recurring theme. We're going to talk about complications. This is one of them. We saw it in the HFOV trial. They did not publish the PCO2 data. We saw it here. Then there was a study in the late 90s that had very good outcomes in both groups. Then surfactant came around and things got somewhat better, but we still had issues. And Dale Gersman published this work in 1995, moderate-sized trial. The mean birth weight was 1,500 grams. Who even ventilates babies of 1,500 grams today? Whoops, we're going the wrong direction here. So, yes, it seemed to work. There was less BPD and no adverse consequences, but this is not the population we treat today. Then there were two jet ventilation studies published around the same time. One with catastrophic outcomes, much higher risk of intraventricular hemorrhage and periventricular leukomalacia or death, but there was severe respiratory alkalosis. So that's a recurrent theme. Jet ventilators and oscillators are powerful devices that can really overventilate a baby. Virtually at the same time, we were running a multi-center trial in virtually the same population, mean birth weight very similar, gestational age very similar. And we demonstrated a reduction in BPD, need for home oxygen. There was overall no increase in intraventricular hemorrhage or PVL. But it was interesting that it was really a matter of strategy. They used a strategy that resulted in inadvertent overventilation because with air leak, the low pressure strategy was appropriate. They applied that strategy to babies with a different disease, and that was the problem. There was a subset in our patients that was also, despite strict instruction to use the optimal lung volume strategy, that was not followed, that had similarly bad outcomes, but it was a smaller subgroup. And then there was a series of studies done in the surfactant era, but we're still talking about the end of the 20th century and the very beginning of this century. And there were generally good results, except for this, which used a flow interrupter that had no improvement in outcome and an increased air leak. This study is another study using a 1-to-1 ratio with a French oscillator that showed lower PCO2 and increased intraventricular hemorrhage. You get, there's a recurring theme here. And then there were the two large trials published at the same time in the New England Journal of Medicine. Both were quite large studies. It's very similar population. And one showed a benefit in terms of BPD and one did not. And why might that be is still a matter of some debate. But you can see that in the UK study, there was no difference in survival free of BPD. In the US study, there was a benefit, and overall survival free of BPD was higher. It was slightly lower incidence of IVH, or high incidence of IVH. And so they were very similar in design, similar population. I showed you they were essentially identical in terms of the actual gestational age. There were some key differences, though, that I'll discuss in a little bit more detail in the second talk that deals with complications. Interestingly, long-term follow-up of the UK study did show benefit in terms of long-term pulmonary function. Essentially, the babies that were ventilated with the oscillator had less evidence of small airway disease. I'm not going to go into the details for lack of time. Then there was a slew of studies still in the more than 20 years ago or so, and a few more recent ones, one from India. I'm not going to go through all of them. Mostly they're quite small. This was a small study that did not that used sensormedics, but some infant star, and did not optimally. They said they used the optimal lung volume strategy, but if you look at the actual data, they really didn't, and there was no benefit. This was another flow interrupter study that had a strong trend toward more air leak. We don't use the infant star anymore. So I'm going to just show a summary slide of what we have in terms of the most recent meta-analysis published in 2015. And you can see there's significant heterogeneity in the findings, with some studies showing a benefit or a strong trend toward benefit, some studies failing to. And part of the problem with meta-analysis is that throws together studies using different devices, different strategies, in different eras, right? So 1990s, before surfactant, is a different population than the most recent one. This last study from China that seemed to show an implausibly large reduction in death or BPD was only published in a respiratory care journal, and I'm a little bit skeptical of the quality, and that's another problem. You're equally weighing New England Journal of Medicine publications with large cohorts to a small study published in an obscure journal. So there are some issues, but overall, I think notwithstanding all of these challenges, we can reasonably conclude that oscillatory ventilation, when used appropriately, when in experienced hands in the right population, using the right strategy, will improve outcome. But it has become more difficult to show benefit of high frequency as conventional ventilation improved, as synchronized mechanical ventilation became routine, as we began to understand that optimal lung volume strategy should also be used with conventional ventilation. And more recently, then actually that volume guarantee with conventional ventilation dates back to the 1990s. And that volume targeted ventilation has clear benefits over what the comparisons were back in at the beginning of high frequency ventilation. So that is the rapid journey through the evolution of high frequency ventilation. And you might ask, is there anything new? And of course there is. It's not that new, actually. As Dr. Rajiv pointed out, HFOV VG has been around for almost 10 years now, but it is not being used as much as I believe, and he believes, and many of us who, I'm sure Manuel does as well, is not used as much as it should be, and we will spend a fair bit of time talking about that. And with that, I will leave you.